Okay, hello everybody. My name is Anna Keenan. I'm a third year. I am doing this case study on a patient with Meniere's disease. So I am doing my externship in an ENT clinic right now, mostly doing audios for ENT patients and then also fitting hearing aids on people that need it. And this is kind of a patient that fit into both of those categories. So I thought it would be nice to present. So I did not originally see this patient. He came in early 2020, and this is his case history and results that I'm going to share. He is a 55-year-old male at the time. This was January 2020. His chief complaint was dizziness. He stated he had had 7 episodes of vertigo in the past 3 weeks. Symptoms included nausea and vomiting. He also felt like he had hearing loss, tinnitus, and oral fullness in the right ear only. He reported a diagnosis of Meniere's disease in 2017. However, he had been asymptomatic since then. The hearing loss was only in the right ear. The tinnitus was kind of a low humming sound, and again, oral fullness. He has no history of noise exposure. No one else in his family has Meniere's, and no one else in his family has hearing loss. As I said, he was asymptomatic since he was diagnosed, and he was told to use meclizine when he was symptomatic. So as far as the tests that were performed, otoscopy was unremarkable. There was nothing that was kind of signaling anything middle ear related or cerumen impaction. His TIMP was type A and within normal limits in the right ear, and the audiologist who performed this could not get a seal on the left ear, so we don't really know what it is, but we can assume that there wasn't anything going on. Here is his original audiogram. So his left ear is completely within normal limits. You can see that there's a huge asymmetry here. So he has a severe rising to a moderately severe sensory neural hearing loss, worse in the low frequencies than it is in the highs. And that rising configuration kind of goes along with how the ENT was thinking about this case. As far as SRT, the audiologist used monitored live voice, confirmed that there was an asymmetry there. It was in agreement with this pure tone average. Word rec was 92% in the right ear, played at 90 dB with 50 decibels of masking, and then 100% in the left ear. As far as what these results showed on the audiology side, we kind of ruled out, as I said, any kind of middle ear involvement. His audio confirmed what he had reported with his symptoms. It confirmed the perception of his tinnitus as kind of a humming sound, and it was consistent with his Meniere's disease being active at that time. His word rec was excellent bilaterally, which is what we would expect in an active state. So kind of all fit together. Everything was adding up. So initially, after he had the audiogram done, he saw one of our physicians. That physician said, I think this is Meniere's disease, and he had him go have a vestibular evaluation. Those results showed a unilateral weakness of the right side, and they said that there's a right peripheral vestibular pathology going on that was consistent with Meniere's. So that's how he was treated. The ear, nose, and throat got those results, and he put this patient on a daily diuretic 3 times a day, and they also emphasized going for a low sodium and low caffeine diet. The vestibular audiologist said, if that doesn't help, then we'll try some vestibular treatment, but as far as what his chart shows, it doesn't look like that ever happened. So they decided that they would just monitor his symptoms and retest his hearing a year later. And that's where I come in. So I did this audio for him when he came back. He was seen for an updated test following treatment, and he was still noticing a difference between the ears. So he reported that he again had Meniere's disease. He still feels like he has a hearing loss in the right ear, although it's not active, and he's hearing a constant humming tinnitus in that ear as well. At this time, there was no oral fullness, no otalgia, otorrhea, or dizziness. So we were pretty sure it's not in an active state. Since he was seen in 2020, he had been asymptomatic as well, and the diuretics were helping. He no longer uses meclizine, but he did state that he has it. Again, his otoscopy was unremarkable. He had type A TIMPs in both ears. His audio is improved from the last time, but you can still see that there's asymmetry there. This time, instead of a rising configuration, it's a gently sloping configuration. So it's going from mild to moderately severe, a little bit different here. As far as his speech, it improved. It was still in agreement with pure tone average, and his word recognition was still excellent. So that's kind of what this says here. Again, otoscopy and tympanometry ruled out any middle ear involvement. It confirms the asymmetry that he's reporting, and his speech tests were where we were expecting them. So his right ear improved in the low frequencies. His SRT improved, his word rec was stable, and his TIMPs were normal. As far as what we decided to do moving forward, I was kind of assessing everything that's been going on and what the right choice is. For him, his treatment and his consistent diet have helped to reduce his symptoms, and he's since been asymptomatic. The ear, nose, and throat that I work with said, I want you to wear hearing aids, and he gave him medical clearance. We went for a unilateral fitting. It's kind of what we had recommended. It's also what the patient was looking for. So we fit him in the right ear. We may consider something in the future as we monitor his hearing and if his left ear changes at all. And this is just showing how I fit his hearing aids, which I think is kind of important. I've never had a patient like this. I don't know if this is the best thing to do, but this is what myself and my preceptor decided. So on the left, you can see this is his hearing aid settings in his automatic program with Phonak. We ran real ear measurements. This is how he felt comfortable. We didn't make any changes. If you look on the right side of the screen, you'll see that the low frequencies, the gain in the lows has been raised quite a bit. And that's kind of our best guess of a program that he can use if his Meniere's becomes active again. Now, we're just kind of going to wait and see if that happens. It's been managed pretty well. And then we can make further adjustments to this programming as needed, depending on how he feels like it sounds for him. So I thought that this was an interesting case because this was really the best example that I had of what it's like working closely with ENT. So a lot of the times I'm just doing audiograms for people who come in for fullness or for cerumen removal or sinus issues, and they don't always come back to us and we get to follow up. However, this patient started out with an audio, then he talked with the ear, nose, and throat about his results. The ENT referred him for vestibular testing, diagnosis, so he followed up with those professionals. Then he came back, had another audiogram, and saw the ENT again. So it kind of came full circle, and I thought that that was a really good example of what it can be like in that clinic. So this treatment process was the reason why we went for it was because it considered his interest or his point of view. The patient only wanted one hearing aid. He was ready to pursue amplification. It really let him kind of take control of what was going on while also listening to the recommendations from the professionals. It also allowed him to learn more about what it's like to have Meniere's, what it's like when it's active, what it can be like when it isn't, and how as a person with hearing loss, those things go together. It was also great because it was a case that involved a lot of interprofessional communication, one for the accuracy of the tests and the results, but also for coming up with a treatment plan that matched what the patient is capable of and willing to do. And I think on the side of diagnostic or clinical audiology, And on the vestibular audiology side, as well as the ear, nose, and throat, all of the recommendations really came together for everybody, and it seems to be working well. My biggest takeaways from this case were making a connection to the hearing aid side of audiology versus the vestibular side. I haven't myself had much vestibular experience other than observing a couple of times. So this was cool for me to see a patient who has gone through everything and then also come back for hearing aids. And I like the way that those two kind of blended together. This was also my first experience with someone who actually has Meniere's disease or has a diagnosis that is pretty much confirmed. I've seen quite a few people who say that they think they have it or their doctor thinks that they have it, and then it turns out that they don't actually have it. So it was nice to be able to walk through from start to finish what it's actually like. It was a great opportunity for me to get creative with how I fit the hearing aid, because it was really kind of using the patient's perspective of how things sound, as well as the gain that's needed when it's active versus inactive. And that is something that I haven't yet had to do, and I'm really interested in seeing how it works out. And lastly, it was a great way to communicate with other professionals and come together on one case. So he was just fit with his hearing aids 2 weeks ago. He'll come back for a follow-up in a week or so, and I'm the one who did his hearing aid consult, and I'm the one who fit him. So I'm really excited to see how it goes moving forward. Feel free to leave any questions that you have, or talk about anything that I missed or you want to know more about. And thank you for listening.